So very welcome, Theresa, and thanks a million for doing this session with us. Theresa Barry is going to talk to us today about SNOMED clinical terminology. So without further ado, I'll hand it over to Theresa. Thank you very much.
Thanks, Joyce, and thanks, Maureen. So welcome, everyone. I'm going to be talking to you today about SNOMED and about data standardization and the value of having standards in data and what that means when we're looking at digital and electronic health records. So this is just an overview of SNOMED, and I suppose the first thing to think about is when we're talking about data and digital health solutions, whatever they may be, if we're going to put all our healthcare information into an application and use that data in a meaningful way, we need to know what would good look like. What do we think we mean when we talk about data standardization, data quality, usefulness of data, and usability? What do we mean? So a few of us have worked together to come up with this, to look at what, I suppose, what is our North Star? What are we trying to work towards when we're trying to standardize our data? So some of the things we're talking about is that all our clinical and our medical terms are standardized. Currently they're not. We've medical terms in all sorts of ways, in all sorts of systems, that our vital information can be shared, so that we can share our medical information between healthcare professionals, between care settings, between locations, to enable our healthcare professionals to have the latest information for continuity of care, that we have comprehensive coverage and greater depth of details and the content for all our clinical specialties and professionals. All our terminologies or standards for medical information should include our diagnosis, our procedures, symptoms, family history, allergies, assessment tools, observations, devices. The clinical decision making is supported, so we need to be able to support clinical decision making by using standards, so that whatever information we have in one system is the same in another system. It also facilitates our analytics and our insights to support more extensive clinical audit and research on population health. And as we all know, in COVID times, population health research, these things, and clinical audit became extremely important, and using data to inform all of this is what we need. But we need good quality data, and that's what we don't have. And reducing risk of misinterpretation or duplications, and supports evidence-based healthcare. And as we know, evidence-based healthcare is really important, because now we need the evidence to tell us what's happening in our healthcare settings. How many healthcare professionals do we need for a service? How do we know how many we need unless we have evidence to tell us what is actually happening in any one area? So that's what we need. That's what good would look like. So in an effort to try and address some of this, myself and some of my colleagues, we set up this process called the data set management process. So this is how to try and enable us to do better with data. And the data set management process is up and running now since about 2019. And so, as we know, data management is a very challenging journey. We have in the HSE, we have a lot of standalone ICT systems. We have, I won't say totally no standardization, but we have little standardization. The data quality is, I suppose, ad hoc, and the governance of data sets is something that needs to be addressed. And we have incomparable and inconsistent data. So data coming from different systems into some sort of a repository and trying to figure out what is what, and does this mean the same as that? And this is what SNOMED tries to address. So just, I suppose, to make the point that the electric light bulb, when we had that, we didn't, things didn't improve just by looking at how a candle worked. So, we're doing a step change. This isn't moving from what we do right now and gradually moving into something else. We have drivers as well telling us we need to do better with Sláinte Care and EHRs and so on. So I'll talk about a little bit more about the drivers that help us with this. And this data specification management process is something that we do monthly. We have a number of subject matter experts who work in the HSE who all manage data in some way or another in secondary use. We also have representatives from SNOMED, including myself and my team, and the data dictionary that sit on the meeting. And the data requester or the data owner brings their data set to the meeting, where all the subject matter experts give some information, some collaboration, some explanation of maybe things they should include, and then this data set is discussed, and then we decide we're going to proceed with bringing it into the data dictionary and into SNOMED to standardize it, to make it available then for applications and systems. So that's the first step. It's not pretty, it's difficult trying to get all our data right, but we have to start somewhere, and this is the starting point we have set up. And I suppose the main thing to know as well, like, what is the big nut we're trying to crack? Like, what is the problem we're trying to solve? Because many people may not think there's any problem. We have loads of health information. It's all in systems, or a lot of it is on paper. We all know what we're doing, and that's perfectly fine. But when we think about the step change and the digital transformation we're trying to do, we're going to have healthcare systems all over the place in different care settings. And now we need to join up this data and share it. So we have different terminologies in different systems, in different formats and different documents. In the center of all this is our patient. That is core, but the patient can tell us different things. That is recorded in different ways in different settings. Obviously, this patient is an asthmatic. They're saying they've breathing problems. They're an asthmatic. They've had asthma attacks, and they're diagnosed with respiratory disease. As human beings, we can understand that. We can interpret that. That's perfectly fine. There's no problem. The problem is we're trying to put this into a digital health solution, and computers don't understand this. Computers don't understand what human beings understand. So SNOMED is human readable, but it's also computer processable. And that's what makes SNOMED interesting and different. So once we have a dataset owner coming through the TSNP, we bring them on to start them some work with SNOMED. And this is just, I suppose, an explanation about SNOMED and what is it. So it's the most comprehensive multilingual clinical healthcare terminology in the world. Ireland is a member of this international body, of which there's now 49 countries members of SNOMED International. Ireland are one of those members. And it's a resource with scientifically validated clinical content that's released globally twice per year. Now it's done monthly from SNOMED International, and still twice per year from Ireland. It enables the consistent representation of clinical content in clinical information systems, health data and analytics, and interoperability solutions. It's mapped to other international standards, which I'll show you there in a moment, and it's adaptable to each country's requirements. So here in Ireland, we have our own instance of SNOMED, which includes everything that SNOMED International has, plus our own bespoke content, so Irish-specific things. And it's used in more than 80 countries. So what is SNOMED, and what's the big deal about it? I suppose the main thing to know about it is not a flat file. It's not a list of every medical intervention, disease, illness you can have. It actually is everything's related to each other. So SNOMED CT has a list of all the concepts, and a concept represents a clinical thought, every concept that has a unique numeric identifier. And then it has a description. So it has a human readable description of what it is. And then it also has a relationship. And everything in SNOMED has information model and the concept model behind it. And as you can see here, we're talking about pneumonia, viral pneumonia. So the causative agent of viral pneumonia is a virus, and the finding site is a lung. And then you can have the infective pneumonia, which is an infection, and a respiratory disease. So everything has a relationship type, and these two are ISA relationships. This is the finding site, this is the causative agent, and this one is the finding site here as well, is the lung. So this is how everything is related, explaining exactly what a viral pneumonia is to a computer. SNOMED CT, as many of you may know, is not the only show in town. There's a number of other reference terminologies. One of them being LOINC, which is quite an important one for labs. We have RX Norm, which is to do with medicines. MEDRA, also to do with medicines. Orphanet to do with rare diseases. NANDA to do with nursing. ICNP to do with nursing. There's a whole family of them. SNOMED isn't the only show in town, but the main thing to know is that because SNOMED is global and because it's international and has such a big reach, what they have done is they've mapped SNOMED to most of these other reference terminologies, or have agreements with them and work with these other terminologies and classifications. And then this is an example from Australia. And here you can see, everywhere you can see this little blue here, this is a SNOMED. And these are all the different types of care settings you can have a patient in. And these care settings are different parts of a record that you would use the various terminologies in. But this is just to represent SNOMED is actually in all of the types of care settings or areas of a record that you would use. And that's the main thing to know about here. Blowing up that slide is quite useful to see where everything fits together. And I suppose just to say it has this global reach and it's applicable in all the various parts of a healthcare record. Where is it used? So here is at the data entry and integration. So you're going to have a digital health solution, having SNOMED at your data entry point and for that integration. So at the point of care when you're collecting the information. And then you use it for the clinical information sharing, so the electronic exchange of the digital data in documents. And then the point of care when we're looking at analytics. So we want to know how many people came through with this, that, or the other disease or illness, and kind of what happened. And then when we pull it all together in a bigger system, we can look at the population analytics, so conducting trends and comparative analysis. So by standardizing our data before it gets into our system, we're getting all this really useful application of the data. And then managing the analytics, so being able to do the trend and comparative analysis, and then ultimately on into research. So that's the circle of being able to use data. And so it's in all of these areas. SNOMED, as I said, it's built on relationships. So in SNOMED, there's 19 hierarchies. Everything in SNOMED is related to everything else. So everything must fit in under the hierarchies. So that's important to know as you start working with SNOMED and start looking at it, that everything is related to everything else and nothing sits on its own. Everything is under one of these concepts. And this is just a map to show you the coverage of SNOMED and the countries that it's in. So it has a global footprint, quite well developed here in the US, Canada, some of the South American countries as well, such as Argentina, and across here in Australia, New Zealand, and Europe now. Out of the 29 EU countries, I think there's 3 that aren't SNOMED countries, so it's been adopted quite heavily in Europe now as well. I'm going to skip over the slide. Sorry, I had there's not really much to see in here. I suppose the main thing to say about this slide and the next slide is, like, why should a country invest in SNOMED, or why should they work on it? And this is just an example of a couple of countries that have been working with SNOMED and some of what they have found using it. So Barts Health in East London said that the benefits derived from SNOMED embedded in the Cerner system for clinical informatics and was a regional EHR and data analytics platform. So they endorse that we use SNOMED. This is in England as well. They agreed that there was a lot of benefits. So it's, the case for investment is quite strong in all these countries. At the center of all this, obviously, is our patient. So the patient, what's the benefit to the patient by ensuring that their data in an application is captured within SNOMED? And for the service for patients, these are the outcomes that a lot of countries have found. So they have found that by recording their information, their diagnostics, their patient safety, infection control, referrals, population health data sharing, and so on, have allowed patient health outcomes improvement in patient safety, in infection control, population health, analytics, and research. And there's, I suppose, a lot of information showing on the power of this. Now, this isn't the end of it. Like, there's also a lot of huge opportunities looking at personalized and precision medicine coming into 2030 and the next number of years. Obviously, big data and AI and natural language processing and so on is something that is SNOMED International are watching quite closely for the, I suppose, possibilities and the art of what might be possible using these things for capturing data and using the data. But using SNOMED in a system, if you have a lot of data and you have a lot of patients with that information, being able to do interoperable and longitudinal cohort reports analysing large populations with genomics, laboratory, lifestyle assessments, and so on, will give you a lot of information on health outcomes using particular medicines or particular approaches to care. And also there's quite a big genomics project going on within the SNOMED International Group as well, around using genomics and phenotypes and understanding how they're built using the data standards as well. There's a lot to come yet. New Zealand have also done a lot of work using SNOMED, and I think this is particularly interesting. This is some of what they found. So I won't read them all, but they had 30% lower emergency department use than the national average, because they had standardized their data, they understood their data, and they were able to interpret the data and use it. And they had a 30% lower acute medical admission. This is the one that interests me the most, that they had in 2019, they had the same bed numbers as they had in 2007 in one part of a certain hospital, while serving a population that had grown by 80,000. So this ultimately is saving them money. So just because they had a bigger population didn't mean that they needed more beds. They had better information and better data and could use it better by planning and being able to organise and structure their information. And this was in Canterbury District Health Board. And I actually met the lady who had worked on this, and she was quite a fascinating lady to talk to. And the other things are kind of straightforward enough, but I think this one for me is the one that's the most interesting. Being able to save money and also obviously better patient outcomes for those patients by not having to be in hospital. So here in Ireland, my title is the Clinical Terminology Architecture Lead, and this is what the clinical data architecture looks like in Ireland. So down here we have the core services that we're doing, and this is mostly what we're doing. So managing the licenses. So anyone that uses SNOMED in Ireland needs a license. The license doesn't cost you anything, and the supplier and the project group need to have a license. It doesn't cost anything, it just keeps you on our database and keeps you updated with what's happening. We're doing education and training. I really need to get new glasses because I have to come in and look here. Our governance, advice and support, creating reference sets, which is what we've been doing a lot of, and the policies and procedures. And over here, we have the partnerships and we have the key resources. So I suppose we do the SNOMED mapping. We have a managed service as well that helps us with the releases. And we have, I suppose, a number of other activities we do under the education and training as well. So that's kind of some of what we've been doing. So we had our latest release in April 2023. And in here, this is some of what we created. So these are the 19 hierarchies, and these are the concepts that we have done. And that one's just a little explainer. But down here, you can see what we've been doing since 2019 and all the way up to 2023, the different releases. So you can see things are growing. So in the last release, we had 304 new concepts. So they're brand new medical terms. Some we keep for our own use that are specific to Ireland, like IHI and PPSN. And some of them then we donate into international that are internationally applicable. And as you can see, out of the 304 we created, that then had 797 new descriptions, and then the language reference set. So that's us using the English language, and that one isn't quite as, that's just exponentially explaining other things that come in from international. But you can see when you plug everything in together and synchronize, the knock-on effect of creating new content. And all of these data sets we worked with and created new content for were ones that came through the DSMP process that I spoke about earlier. Some of the projects that we authored and that we worked with in the last year have included the National Ambulance Service, the dentistry reference set. So they're doing a very big project and getting a new system this year, and we did quite a lot of work with them. Breast screening, so they have a new reference set and they have a new system coming out this year as well, and standardizing their data is work that we've done. And an oncology nursing discharge group. Then we also have created, we've done a lot of work with the Irish Pharmacy Union on pharmacy or pharmaceutical concepts that need to be done for them to standardize it using the SNOMED terms. Patient flow is one that we've worked with. The client health questionnaire for the Ukrainian crisis, we've worked with them on a data set as well. The organ donation, epilepsy, and this one, the National Electronic Research Management System workflow. These have all come through the DSMP, and these are all data sets that we are standardizing. Ongoing work we're doing is with the MNCMS. They use SNOMED and St. James's in their systems, and they're going to be updating the versions they have of SNOMED later this year, so we're working closely with them. The National Rehabilitation Hospital are getting a new system later on this year, and we're working closely with them. The Children's Hospital, I'm sure we're all aware of the work that's ongoing there, and we're working closely with them. The Mater Private are also doing a big implementation with another supplier this year, and we're working closely with them, even though they're not in the HSE, but the SNOMED license and the National Release Centre for SNOMED is for Ireland and not just particularly the HSE. And the Shared Care Record is the other big project that we're doing a lot of work with. So what are the drivers for change, and who's saying we need to do anything? And I'm keenly aware of the time, so I'll try and speed up here. I know there's a few questions. So basically, the European Health Data Space is something a bit like GDPR that's being discussed at the EU Commission level. And this is about enabling, or not enabling, but allowing all citizens to have the right to access your health data and to share your data and to be able to see your data and to be able to move it between care settings. And that's in planning at the minute. That documentation probably in the next year or so could come into being. And if that happens, it means that we need to be in a state of readiness to be able to provide, to share our data in a standardized way between healthcare settings. And the My Health at EU is also a project I'm working on as well. I sit on the Semantic Task Force and represent Ireland on that. And there's a lot of work going on there around e-prescriptions, patient summaries, hospital discharge reports, laboratories and radiology, and sharing data in those particular use cases. These are from the national contact point and that European work. This is just a slide on some of the countries that are already gone live, and Ireland is in the planning of these. So I think that's my last slide. So I have a link in here for the My Health at EU for anyone that wants to know more information about that. A link into the SNOMED browser, and then I put a lot of content up on the eHealth Ireland page as well to keep information up to date there. And then this is the SNOMED International, their actual page as well. So if you want any more information, you can contact me or the SNOMED at hse.ie. I'll stop there.
Thank you, Theresa. As you can see, we have a few interested parties here with questions for you. And I'll apologize in advance because I'm probably not going to pronounce this right, but we'll get straight into the questions if you're okay.
Yep.
So SNOMED, CT and LOINC or whatever, LOINC.
Yeah.
LOINC were included in the laboratory care settings on slide 11. Should both be used, or is the LOINC for lab and the SNOMED for specimens and diagnostics?
Yeah, great question. So that was a debacle that was going on for quite a while. So in September 2022, LOINC and SNOMED have reached a new agreement where they're going to actually create the LOINC content in SNOMED using the SNOMED modeling and the information model in SNOMED. So that agreement and that mapping work is currently being undertaken by SNOMED International, and they're hoping probably in the next 12 to 18 months to have that available. So then you download the SNOMED reference sets or the SNOMED content, and you'll have all of what you need with LOINC and laboratories. So it's trying to work collaboratively so that you don't have to try and manage both, basically.
Okay, Theresa, thank you. Is there any difference between ICD-10 and SNOMED? Or
Yeah,
what is the difference?
So the difference is, so ICD-10 was something that we used before we had digital health solutions. So when we were on paper and we needed statistics to know how many hip replacements we did in the hospital. So for statistics, that's what it was originally intended for, and then became used for reimbursement and payment. But it was never intended to be used at the front end of an ICT system. That was not its intention, even though it has been used because there was nothing better to use. But now SNOMED is what we need to use at the front end of the system. And again, like I showed on the slide there, SNOMED have done a lot of work with ICD-10 and creating maps. So the idea is that you can record your information in SNOMED, get an output in ICD-10 for the statistical and reimbursement purposes, so that you can use both, but not ICD-10 on the front end of the system.
Okay, okay. Are Irish specific medical terms reflected back into the global terminology databases?
So we've worked, so some of the systems we've worked, or some of the projects we've worked with, like dentistry and breast check, specifically both of those, there was a lot of content on the breast check side around the cancer diagnostics, some of which was not in the international edition of SNOMED. And we worked closely with the SNOMED international teams. And when there was new content required, then we create it on our platform, but we donate it into international. So then it can be used internationally. So sometimes, like maybe 90% of what you want is in SNOMED, but depending on what domain people are using, as medicine changes, as science changes, there's more content required, and then we can inform some of these things. So there was quite a lot in the dentistry as well, because there was newer things needed to go in, and some are specifically Irish things, like I said, the IHI or PPSN, but a lot of most of them then are internationally applicable because the same diseases or procedures are being carried out internationally.
Okay, okay. Theresa, very quickly, a final question. Are there any plans to implement a SNOMED CT terminology server accessible from the HSE network, which could be queried directly by clinical applications?
Yes, very good question. So we're just got the stamp of approval for funding with a business case to do this. So we're going out to procurement now in the next few months, and that is for a central terminology server, so that applications can connect to the central terminology server, have all the standardized data, bring it into their systems, use it, and you'll be actually using an API to keep up to date with medical information, and everyone's working literally off the same hem sheet. And that's more, you'll be hearing more about that in the next few, well, hopefully early next year we'll be ready to go to work on that for all the newer applications. So it really enabled the applications to be up to date and use all these terminologies in a lot easier, more seamless way with APIs rather than building databases and so on.
Theresa, and one final one, I didn't realize, HYPE and SNOMED, do they tie together, or?
That's back to the ICD-10 SNOMED question. So as I said, SNOMED at the front end of the system, and you can get a mapping out to ICD-10, and then that informs the HYPE department, and that's how it can be used. But in each project, you need to tease that out with the HYPE department and reach agreement if you're going to use the maps, or whether you're going to collect everything in SNOMED and give a PDF document across, or give them access into the system. And they still need to assign the ICD-10 codes for that reimbursement and the statistical purposes. So they still need to do that work. One doesn't replace the other. They have to work in harmony. Yeah.
Okay. Okay. Theresa, thank you so much for that. A lot of questions, a lot of interest, obviously. And hopefully people who were away, we still had a pretty good attendance today considering, so it's great. So it was well worthwhile, and hopefully people will access the webinar that we'll have on HSE Land after a little while, and on our eHealth Ireland website actually as well. Just very quickly before everybody goes, our next Lunch and Learn, 30th of June, is with Marie O'Hare, not in eHealth. She is a part of organizational development and change. So it's tips around, I guess, dealing with change and all of that, which is interesting, I would imagine, considering the environment we're in, to everybody. And then at some point in time in July, we will have an update on all our cyber program from John Warder, one of his team. And we'll also be doing a Q&A with myself and Michael Redmond. session. So look forward to seeing you all again very soon. Enjoy the bank holiday weekend. Again, thank you so much, Theresa. That was so interesting. You hear all the time how powerful data is, but you know, when you see it in a real the results of it, like the New Zealand example, it's amazing, really, when you can see it so clearly affecting patient care, which is amazing. Again, thanks everybody. Thanks to Mairead and Thomas as always for organising, and we'll see you all in a few weeks. Enjoy your weekend. Bye bye.
Thank you.
Thanks, everyone. Guys, if you just want to hang on there for a second.